episode of Retina Chats. I'm Mohammed Ghunaim, and with me Dr. Mustafa Al-Manhali.
Hello, everyone.
So today I'm presenting a case of 30-year-old patient. He presented to me with an old trauma managed by sutures to the cornea and ultrasound showing an intraocular foreign body. So, and of course, vision is hand motion, and he has a white cataract. So here I'm starting with the main incision, doing the side ports, and I then proceed to removing the cataract. I'll inject trypan blue dye to stain the anterior capsule. Here I'm breaking up the synecdoche. So what's your plan here in doing cataract surgery? How do you what do you expect? Of course, the posterior capsule is not intact. So how do you proceed with this? Do you do a phaco? Do you do a lensectomy from the start?
No, I will do a phaco trying to salvage as much of the capsule or even the sulcus to add a three-piece
Okay.
instead of doing a scalar fixation or adding an artisan.
But I mean that posterior capsule is not intact. We know for sure there is a foreign body
So we
penetrated.
can maintain the sulcus or the anterior axis if present, and I can add three-piece.
Okay, so yeah, here I did just by injecting viscoelastic, we can see that there was a deepening of the anterior chamber. This means that there's no need to go with a phaco probe. So I did a lensectomy. He's a young age, so the soft nuclear matter. Then going inside the eye, we can see that the foreign body is just attached in the mid-vitreal area. It's not doing any harm to the retina. So how would you proceed now?
I will complete all the vitrectomy and trying to secure this intraocular foreign body without pulling over a vitreous or without attacking this before removing the complete vitreous. Maybe I'm not going to do a PVD to leave some of the vitreous as a cushion over the macula,
Okay.
but if I found it that it is not that flexible or malleable, completely free, I will do a complete vitrectomy and even do a PVD. Then I will try to remove the.
But you know for sure that if you do a complete vitrectomy in this case, the foreign body will fall down on the retina and maybe injure the retina.
Sometimes I add a PFCL bubble over the macula.
Okay.
And some reports confirm that it protects and it helps from injuring the macula. Others see that the PFCL bubble is not protecting.
I believe so, that PFCL bubble doesn't do any benefit.
That if the foreign body, after you try to remove it and it fall from the anterior segment back to the macula, but if it is in the vitreous cavity and you are trying to do a vitrectomy and you're trying to avoid the foreign body to come over the macula, definitely this bubble will keep as a dropped nucleus. When you add a PFCL bubble, you keep this nucleus outside of the macula. So the same way it's going to happen for the intraocular foreign body. You just try to avoid it coming over the macula, so you pick it from the macula, and even the indentation or holding the forceps over the macula may sometimes do a pressure points over
and injure the retina. Yeah.
So leaving this PFCL bubble will keep this outside the macula, so you can take it from outside this area.
In my experience, it just makes things harder. And even in dropped nucleus, I don't put a PFC bubble. When I tried this, larger foreign bodies or denser foreign bodies usually just penetrate the PFCL, and it makes things.
If it's falling from the anterior segment, but if you are doing vitrectomy, it's not going to fall over the macula.
Okay, so what you're saying is the classical teaching that you have to remove all the vitreous before attacking the foreign body. But here I found that the retina is just completely normal, and I was afraid to injure the retina by the foreign body falling on it. So here I tried rather unorthodox way. So I'm going here with the foreign body forceps, 23 gauge 1 basket forceps, and just holding the foreign body mid-vitreous with slight traction on the vitreous, and then with my other hand going with the cutter and releasing the vitreous mid-vitreal before prolapsing the foreign body out of to the anterior chamber. I know there's definite traction on the periphery, but I thought that I could go away with it without doing any harm. So now foreign body is released from the vitreous, and I'm prolapsing it through the PC rent, or the anterior capsular rent, and then using the iris shelf technique, placing it on the iris and going again with the foreign body forceps from the main wound and extracting it outside the eye. So this way, okay, so there's definite,
So you completed vitrectomy afterwards?
yes, now
Okay, thank
completed
God.
with completed vitrectomy from this area, and I'll check with indentation that there is nothing, there's no retinal tears, no injury to the retina, and it was fine. And then proceeded with IL implantation. So now the anterior capsule is intact, or most of it is intact. We can put a three-piece IL in the sulcus. The other way that you can do this is by putting a chandelier and then holding the foreign body with one hand, cutter with the other hand, releasing the traction from the vitreous, and then getting it out safely without even also making it fall on the retina. So, are you advocate of this way?
Definitely no.
Why not?
Adding a more sclerotomy for a step that is not cost benefit for such a surgery. I myself use a chandelier for traction retina attachment that could not be done unimanually.
Okay.
So if you are doing this surgery and even you are removing the foreign body without completing the vitrectomy and getting it from the mid vitreous and there is no retinal detachment, why the hassle to add one more step and add the chandelier just to hold it down? So you can do the vitrectomy around and you can free from all the
But it will
attachment.
fall on the retina and maybe injure part of the retina.
So the other way, you can just add a small bubble of the PFCL and you can save.
Okay. So there are different ways to do everything in surgery, especially in vitreoretinal
And this
surgery.
is a third way that no PFCL bubble, not chandelier, and you have removed it.
Yes, but just for the fear of
Traction.
pulling on the vitreous base and causing a tear. I went, it went fine here, and there was no tears, and the patient did well. But on another day, you could have had traction over the vitreous base and cause a retinal tear. So if you put theoretically, if you put a chandelier, you can hold the foreign body with the forceps, and with the other hand release it from the vitreous without making it fall down, and extract it outside the eye. So would you put a tamponade here? I left the patient on saline. I didn't put any tamponade, not air, not gas, not anything.
Usually, I prefer to leave it on half filled,
Okay.
so 50% air, just to secure the sclerotomy. I don't like to leave patient on saline.
Okay. Here, after ending the surgery, the IP was okay, so I didn't feel the need to add gas or air to seal the sclerotomies. So I just left the patient on air, on saline, and it helped in an early recovery. And the patient was seen the next day around zero point 0.2 or zero point 0.3 vision, so it went well. But again, it's just the risky part of pulling on the vitreous. Would you do anything differently rather than the PFCL and the?
I would just try to completely free the foreign body, even if not adding the PFCL and trying to lay it down over the retina, then remove the vitreous and trying to attack the foreign body after securing that there is no vitreous inside the cavity.
Okay, what about dropped ILs? If you have a dropped IL in the same situation, would you add a PFCL bubble or just
Yeah,
let it fall on the macula?
dropped IOI.
Yes. You said that if you have a dropped nucleus, then you would put a PFCL
No, I don't add it
routinely.
routinely. Yes,
Okay.
I'm just giving an example that when you add this BFCL bubble, it shifts this nucleus from the macula.
Okay.
So it's going to shift this foreign body from the macula. So you can attack it outside from this sensitive area. But if it is falling from the anterior, if you're trying to grasp this intraocular foreign body and trying to remove it, then it it slips down and it fall over the retina. Definitely, it will penetrate this BFCL bubble. So My
So
point
the higher
is,
the fall, then it would fall on the macula.
yes,
But if it's in the mid vitreal, it falls down on the periphery and not on the macula. Okay. Okay, so that's the conclusion of this episode. Thank you very much for watching. Stay
thank you.
tuned for the next one.